we can start this webinar today in an unusual day, as yesterday was Easter, so we moved to the Monday after Easter. Happy Easter to all of you. Today we have, of course, our mentor, Professor Yoko Kato, who is always here with us, supporting us. Thank you, Professor. And a special thank also to Dr. Liu Bunseng for his help in the organization, and also to Raja for the same reason, but also because today he's our commentator. So thank you, Raja. Also, I want to thank my co-moderator, Professor Ishu Bishnoi, who is not able to join us since the beginning because of an emergency in the OR, but hopefully he will join soon. And thank you to our discussants, Dr. Sukirti Chawan and Dr. Biswas. Today we have two speakers, as usual, Professor Calvin Mack and Dr. Niveditha Manjunath. So thank you to our speakers. Before introducing the first speaker, let me ask Professor Yoko Kato to give some words of introduction to this webinar. Thank you.
Thank you. So happy Easter. I think maybe you have a good time with your family. So I think today is two good speakers. One is ladies, of course. She just left a few days back to India. So Calvin Mack is Ben's teacher. I think I met him. He's a very clever and also very hardworking doctor. And we are very much looking forward to the speakers. Thank you very much.
Thank you, Professor Kato, for your words. I think we can start. Professor Calvin Mack will join us online in a few minutes, but he provided a pre-recorded presentation. He's actually traveling right now, but I am very confident he can join for the discussion.
He joined just now.
He joined? Oh, great.
Yeah.
Hi,
hello, how are you?
Hi, I'm fine. I am at the airport in Okinawa right now. So
yeah, I know.
Yeah.
Yes.
So the network may be a little bit unstable, and especially when I go through the security, I might to drop off the line for around like 10 minutes or something.
So Calvin, thank you very much for joining us, although you are traveling around the world. We are very happy to see you. Let me introduce you to the audience before sharing your pre-recorded presentation. And hopefully we will have a few minutes before you board for a short discussion about your topic. Professor Calvin Mack is not only a consultant neurosurgeon at Queen Elizabeth Hospital in Hong Kong, and also clinical associate professor at the Department of Surgery of the Chinese University of Hong Kong. He is also a dear friend of mine and a dear friend of ACNS and Alumni Association. He is very well known for his skull-based skills, especially for endoscopic approaches. And today he will talk about Bipportal endoscopic, transorbital, and endonasal approach for invasive pituitary tumor. So we are very happy, Calvin, you were able to join us, and I will try to share your presentation. Let's see. Hopefully you can see my screen.
Yes.
Okay, I can start the presentation by Professor Calvin Mack.
Hello, this is Calvin Mack from Hong Kong. I work in Queen Elizabeth Hospital and is also the Vice President of Hong Kong Neurosurgical Society. Today, I'm going to share about the topic on bipportal endoscopic transorbital and endonasal approach for invasive pituitary tumor. So this is the lab in my hospital, which has 5 to 6 stations. This is where we train residents and also fellows on endoscopic and also open skull-based approaches. So if you're interested, you feel free to join us as well. So back to the topic today. So for pituitary tumors or PITNETs, endoscopic endonasal approach has become the standard of treatment. However, challenges still exist. For example, functioning PITNETs require total excision to achieve a cure. And rare times, these tumors have cavernous sinus invasion, either NOPS 3B or 4. And it's also difficult to have a gross-total resection for tumors that have extension to the Sylvan fissure, or those recurrence after previous surgery, and worst of all would be those after radiation therapy, for example, gamma knife. Therefore, advanced operative techniques are necessary in order to treat this kind of difficult PITNETs. This is the classification for pituitary adenomas. I have the privilege to meet Professor Nobs in Austria in the IFNE meeting last year. And this is the grading about the invasiveness. So for 3B and 4, they are very invasive, fibrous, and therefore studies have shown that they have a much lower gross total and endocrine remission or resection rate. This is another study that also proved the similar findings that NOPS 3B and 4 are difficult to cure with a standard or even extended endonasal approach. So therefore, we have experience of using an endoscopic transorbital approach to different scalp-based pathologies, and we think that this is a very good adjunct to combine with the endonasal approach to remove extensive PITNET tumors, especially with lateral extension. So the concept is that the orbit acts as a window to the scalp base. Now, just posterior to the orbit would be the anterior cranial fossa, the middle cranial fossa. The inferior to that would be the infratemporal fossa and the pterygoplatean fossa. Now, medial to the cavernous sinus would be the paranasal sinuses. That are the compartments that can be accessed by the EEA, the endonasal approach. So this is a schematic diagram that shows the different angles of attack different approaches can offer. The yellow arrow is the craniotomy, the open approach. It's of course very versatile to the cavernous sinus and also the orbital apex. However,
Alberto, it paused. Can you play?
This requires a lot of bone work, drilling, soft tissue retraction, and also brain retraction. And therefore, the patients usually requires more time for recovery. So the green arrow is the EEA approach, the endonasal approach. This is, of course, very good for midline tumors, for cellular tumors, for plantar meningiomas, or for clival lesions. However, when we need to cross to the lateral part of the cavernous sinus, it would not be easy. It requires drilling of the pterygoid plate, for example, and sometimes even sacrificing the median nerve or in order to reach the lateral compartment of the cavernous sinus. And sometimes even we need to mobilize the carotid artery, which can be dangerous to both the vessel itself and also the intima, which is the inside itself. So this is not a very direct and intuitive approach, especially to the lateral cavernous sinus wall. And so the blue arrow is the new approach via the transorbital route. It offers a very direct and anterior access, and it's actually a paramedian access to the lateral part of the cavernous sinus. And without crossing the neurovascular structures, we can easily have the approach to the cranial nerves lateral to the cavernous sinus. So when combining the endonasal approach and the transorbital approach, this actually offers a true 360 degrees approach to the cavernous sinus. And therefore, for PITNETs, we now seldom require to perform the transcranial approach. So when we look at the literature, there are two similar names that actually are interchangeable. ETOA, endoscopic transorbital approach, which was and actually it's equivalent to TONES, transorbital neuroendoscopic surgery. The first name is more favored by neurosurgeons, and the second name, TONES, was actually in the literature suggested by Chris Moe, an ENT surgeon, published in 2010. This approach, ETOA or TONES, actually, as mentioned, offer minimal access and minimal invasive surgery. Is a direct and anterior paramedian approach to the IC and cavernous sinus with a very good cosmetic outcome, which we'll cover later. And most importantly, when compared with EEA, there's much lower chance of CSF leak. So for the incisions, that's step one. We usually use the lid crease incision, that's a B incision. Sometimes for beginners or for selected cases, we also still use the sub-brow incision, the A incision. For the exposure-wise, A and B actually offers very similar exposure, but cosmetically, the lid crease incision is still better. And the next step is to do the bone drilling, the bone removal. We put in the 4 millimeter endoscope. After we handle the orbital rim, either we can shave it, flatten it, or we can remove the orbital rim to create more surgical freedom. And then put a 4 millimeter rigid endoscope. And this is the first structure that we see. This is the meningo-orbital band, which is the lateral most part of the superior orbital fissure. Here's the periorbiter. And between SOF and the IOF, the inferior orbital fissure and the superior orbital fissure, here is the lateral greater wing of sphenoid, which is equivalent to lateral orbital wall. And here's the periorbiter. And after we drill the greater wing of sphenoid, here is the temporal dura, and go down, here's the floor of the middle cranial fossa. Endoscope is actually, I would say, has no contradiction to open skull-based approach. It's actually, to me, it's just a new tool to apply the same skull-based anatomy and microsurgical skills, because I am both an endoscopic and also an open skull-based surgeon. So I use the same concept. So just look at these diagrams. These photos here. This is the periorbiter and the temporal dura. So you see, actually, it's the same anatomy that we see for the open approach, for example, FTOZ, the exposure that is we see the third, the fourth, the V1, V2, and V3, and here's macroscaphe, and there's the rotator body. It's just the same. So when we look at these triangles, it's exactly the same as the Tollens approach, which now with the endoscopic transorbital approach, I call this a reverse Tollens approach to the cavernous sinus. We can go through the Parkinson's triangle between the fourth and the V1, and also between V1 and V2, here's the anteromedial triangle. And by going through the maxillary struct between V1 and V2, we can also have the biportal access to sphenoid sinus, which is very important, especially for our case here with the invasive pit nets. And between V2 and V3, we can even go down to the infratemporal fossa and the nasopharynx for example, malignant tumors and for carcinomas. So when we open between the V1 and V2, here is the abducens nerve, and going posteriorly, that's the Dorilus canal, and here is the carotid artery. So our center here in Hong Kong, Queen Elizabeth Hospital, since 2020, when we started, we have performed over 70 cases. Now it's actually approaching 80 cases of transorbital. So we work with the ophthalmologists and sometimes the ENT surgeons as well. So therefore, we have the advantage of learning and using different approaches as well. But mainstay is the lid crease and sub-brow incisions. So the basic indications include orbital lesions, for example, orbital tumors, schwannomas, vascular malformations, sphenoorbital meningiomas with very good indications to start off with. This is a sphenoid wing meningioma. This is very intuitive and direct approach when we just drill off this lateral wall here. That's a greater wing of sphenoid, and here would be the tumor itself. Lateral cavernous sinus lesions, for example, trigeminal schwannomas, are also very good indications. And of course, frontal sinus pathologies like mucoceles or CSF leaks would be very good base indications. Advanced indications include tumor at the brainstem, petrous apex, or intrinsic lesions like amygdalo hippocampectomy or mesiotemporal glioma. So this is a craniopharyngioma that has recurred many times. I do endoscopic transorbital approach to decompress the brainstem, and the patient previously was wheelchair bound and can be able to walk afterwards. And I'm going to focus this lecture about the multiportal application, especially for the invasive pit net, which I'll illustrate. So here is the operative setting. Patient is supine and then face towards surgeon. So if we want to employ two teams, first of all, we need to have two screens to show the two endoscopes. And here's the EEA team that stands here at the side of the bed, and the transorbital team was sometimes either stand at the head of the patient. But sometimes actually these two teams are actually standing side by side. And for me, actually, I do both. So I would be the one who would do the both roles here. So I switch from position to position. Assistant will usually be standing here. So this is the case I want to illustrate. This is a NOPS 3B, recurrent invasive pit net at the infratemporal fossa. Patient with a previous EEA done and also gamma knife. So it's a difficult case. The tumor is going to be tough and fibrous. So here's the case. So first of all, this case we use a subrine incision because it's one of the earlier cases. And then we put a 40 mm endoscope, that's the mandible retractor, to protect the periorbiter. And then we drew the greater wing of sphenoid. And afterwards, when we continue to drill, here is actually the tumor, because the tumor is actually infiltrated into the greater sphenoid. And then this tumor is usually intermingled with the marrow of the bone, and then we can remove it with suction and also forceps. So this is the temporal dura. Here's a V3. We're now using the 30-degree endoscope and point downwards. This is the V3. Here's the temporal dura. So in this case, actually, I did not need to use the endonasal corridor because I can remove the tumor just by the transorbital corridor. So that's a V3, and here's a V2. And I continue to remove the tumor with suction and the forceps. This I'm a bit lucky for this case. It is not as fibrous as I thought, so it can be removed by a suction. So the surgery is relatively easy. And after irrigation, there is no need to do any cauterization. And then the tumor has been removed, and there is no need to do any reconstruction for this case. I just use a Surgisil and then tissue glue. So post-op, the patient has a very good outcome with a good cosmetic outcome, and there's no recurrence so far. This is another case of a NOPS 4, a biportal case that I did. Tumor invaded the cavernous sinus and the infratemporal fossa. And this is a recurrence case, previous surgery done with the endonasal route and also with the radiation done. So that's why I need to use an extra corridor via the transorbital route to remove the tumor at the lateral aspect of the cavernous sinus that is lateral to the carotid artery. So here's the surgical video. Again, similarly for the incision, but this time I use a lid crease incision, and I use the lacrimal keyhole approach, that is to flatten the perorbital rim to create more surgical space. And here we cauterize this little artery here, and then we drill the middle fossa, drill until we see the middle fossa dura. This is a greater ring of sphenoid. We use I like to use a calcium longa to do the removal, and then here's the sagittal crest that I remove with pituitary longa. And cauterize and cut the meningo-orbital band is a very important and basic step to unlock the temporal dura away from the periorbiter. And then here's the middle fossa floor. Here's the temperatura. So I drew between the V1 and V2. That is the Mullen's triangle. So here you see the tumor. Here's more fibrous than the previous case, and mixed with the bone there. And here's the pterygoid muscle. That means I'm reaching into the infratemporal fossa already. Here's the V2. It's not the V1, but the V2 branch. And then afterwards, we switch to the endonasal approach. You see the previous evidence of previous endonasal surgery. So I just skip through the video with the endonasal approach, but just also highlight the use of the ultrasound is very helpful to identify this complex tumor. So you see the tumor here within the cavernous sinus. Here's the carotid. And again, I use the ultrasound again to visualize the setup part of the tumor. And the knee that I need to extend more superiorly, so I drill the tuberculum sedi there, and then start to do the bulking, and back to the cavernous sinus. Here's the carotid artery, so you see how lateral I am already. And here is the most lateral part that I can reach. Here is the pulsating arachnoid, so it's median nerve, it's a petrous, and it's cavernous ICA. But then we still see that there is a tumor behind, especially lateral to the cavernous sinus. So then I switch to the bipportal excision. So you see the two monitors here. And here's the suction that is sticking out from the transorbital corridor. Here's the endonasal view. And now I switch to the transorbital view. And then similarly, I see the tumor. I mean, the instrument sticking from the endonasal part. This is a malleable suction, the malleable electromagnetic navigation that I like to use to check where I am. So now I am using a bimanual approach. Basically, I push the tumor into the nose and then do the removal of the tumor at the cavernous sinus from the medial side. So I do not need to cross the cranial nerve. So ultrasound so that it's a good resection. And the reconstruction is important. I harvested the nasal septal flap in order to cover both the arachnoid with a minor CSF leak, and also to cover the cavernous sinus as well to prevent any ascending infection to the periorbita. So reconstruction with a Duragen and also the nasal septal flap, and also fat as well. So this is post-op day 1. There is no cranial palsy. If I just use the endonasal route, I am afraid that I will cause early 6th nerve or 3rd nerve palsy because I need to cross the neurovascular structures, which is not good. With the endonasal, I mean the transorbital route, we are also able to do the optic nerve decompression and also remove the ACP as illustrated here. So the last case that I want to walk through is this, again, very invasive PITNET, NOPS4. This time is not only invading through the lateral cavernous sinus wall. There's a little bit of invasion, but the difficult part would be the superior lateral extent of the tumor through the oculomotor triangle into the sylvian fissure and also the frontal base as well. Patient is even more challenging is that the patient has a perfect vision. VA is 1.0 and young patient as well. She does not want to have a radio surgery. She is not from Hong Kong. She resides in the Philippines. So there's difficulty for her to have a regular follow-up. So we decide to have a radical resection for her. Surgical steps. First step is extend the EEA. Open the nose first and try to remove as much as possible. And then followed by the transorbital, and also remove the anterior canal process to expose the MCA, and then bipportal excision. So here's a surgical step. It's quite a long video. I need to skip through the key steps. So opening up the sphenoid ostium, and then drill the sphenoid, the seta. You see the tumor already disinvaded into the sphenoid sinus. So this is relatively easy to remove the sphenoid part of the tumor, and then open the seta floor. You see how thin the bone is. And then durotomy, I like it to open in a cruciate fashion, and then remove the seta tumor. with a dissector and try to do a pseudo capsule resection in the beginning to remove as much as possible, and then afterwards, for this cavernous sinus tumor, there is I need to open up the medial cavernous sinus wall in order to enter into the tumor in the cavernous sinus, and there's descent of the arachnoid. And then here is already the left carotid artery. So this is the OCR. Here's the ICA, and we'll also see the third nerve here as well. And in order to try to remove as much as possible from the nose, I decided to drill the plenum. But still, after drilling the plenum and use an angled endoscope, 30-degree and angled instruments, I still have difficulty. Let me go back a little bit. I still have difficulty to reach this part of tumor that is extending through the oculomolar triangle into the sylvian fissure. So then I do the lid crease incision with the orbitotomy. This time I remove the orbital rim in order to have more working space. Here's the MOB and drill the greater sphenoid. And then do an interdural dissection. And here is the anterior clinodectomy. So I go up, and here is the orbiter, periorbiter. And here is the anterior clinal process. I use the eggshell technique just like I use it with the open approach. And then I remove the hold of the anterior clinal process. So here's the ACP, is quite large. And then open the frontal dura. After opening the frontal dura, I see the frontal lobe here. Of course, I use the cottonoid to elevate the frontal lobe. And then I can see the tumor shortly here. And so here's the tumor, and that's the frontal lobe here, and here is the tumor. And I can also see the M1. The M1 is here. Now, by removing the tumor by suction, I'm able to remove the tumor at the sylvian fissure and also extend it to the plenum. And then I go back to the anonasal part. I remove the tumor with both sides with a bimanual technique. And then finally, we're able to achieve a gross total resection through the oculomolar triangle and also the tumor at the sylvian fissure. Repair is the same. I put in the nasoseptal flap, fat, and glue. So post-op, the VA remains perfect. There's no diplopia and no CSF leak. So these are some of my patients with very good cosmetic outcome. Usually, most of them had an excellent outcome. This is a book that our team has published alongside with some publications. This is my team with the ENT and ophthalmologists. I learned a lot from them. I think it's very good to have a cooperation with different teams when we start. So in summary, for invasive PITNET, surgical resection via EEA remains a challenge, especially at the inferolateral aspect of the cavernous sinus, infratemporal fossa, and the lateral extension to the sylvian fissure. ETOA offers a direct anterior paramedian approach to cavernous sinus and middle cranial fossa. Bipportal approach will be possible to achieve a gross total resection of a tumor with a push-to-pull removal technique, which I've mentioned. Superior visualization by manual resection from complementary angles from endonasal and transorbital approaches possibly reduces cranial nerve palsies and better control of ICA and MCA. Finally, this is the World Congress of Young Neurosurgeons, which is going to happen in Hong Kong on the 30th of October to the 1st of November, 2026. You're welcome to visit our website here, and here's the QR code. And thank you very much.
Thank you very much, Calvin, for this wonderful presentation. Really amazing. I want to open the discussion, and so I ask our commentator today, Professor Raja Krishnankuti, to give his comments and eventually questions. Thank you, Raja.
Well, thank you, Calvin, for this wonderful lecture. I know you are one of the pioneers of ETOA, along with other giants like Theodore Schwartz and many others. So this Bipportal, it has currently been coming up before this endoscopic transorbital came up. Generally, the invasive lateral to the invasive adenomas lateral to ICA were regarded as not so much resectable. But recently, I found an article which came from Stanford about the medialization of ICA, and there also, like when you showed the lesions type 4B and 3, which were very difficult to remove, and it is also difficult to remove through endoscopic endonasal approach also. So this tumors lateral to ICA were usually sent for radiosurgery. So I know this approach is being also now one of the main approaches in Osaka, where Professor Goto spends his surgeries lateral to ICA, most of which he can remove through endonasal are removed through endonasal, and a part of which are outside the realm of the endonasal are removed by ETOA. So in this, I would like to ask one thing, that the sixth nerve is one of the main nerves which can have a dysfunction post-operative, because it's very flimsy and it's difficult to make out within this complex fibrous lesions. So do you use a intraoperative monitoring to detect the sixth nerve?
Yes, hi. Thank you, Roger. First of all, can you hear me? I'm just checking the audio because I'm at the airport right now.
We can hear you.
All right,
Yeah,
so,
yeah.
All right, cool. For the sector, in my opinion, I do also extend the endonasal approach for not 3B and 4 pituitary tumors. But then from that angle, from endonasal, it is always almost impossible to see the sector well, because it is at the lateral wall of the capital sinus. So when we go from the transorbital side, that is, it is going lateral to the sector, then we can actually see it better, and we can see it even at the level of the SFX when it exits the cranium into the orbit. So this would be better to visualize the whole course of the sector for transorbital route, because we can also proximately we can reach to the duodenal canal. Now, so we can visualize it, and the technique that I do during the operation is that to push to remove technique. So it means I do the transorbital route, I push the tumor inside into the capillary sinus, and then because of the support, just like a hand that I stick in from the lateral side, and then so I can use a suction or bipolar or whatsoever process, I can remove the main bulk tumor from the endonasal route. So this is the way how I do it, and it's better to visualize and preserve, therefore, the function of the system with the bipolar effect.
Thank you very much, Calvin. One another question is that the inferolateral trunk is one of the main hindrance that tethers the medialization of ICA. So in your series, did you coagulate this trunk before you medialize the ICA?
Yes, we always almost always encounter the inferolateral side with this approach, and it's important to visualize it early and to try to control it as well. Especially it's true for meningioma, because it's usually hypertrophic, and that would be the bleeding source. So it's important to identify early and can cover it. In some cases, the invasive pituitary sometimes it's pushed away, so I don't need to remove it, or I don't need to quantify it if I don't see it. Just to use a suction and then preserve the fibrous bands as much as possible.
Right, thank you very much. We can take other questions from other panelists also.
Yes, I also have another question. I kindly ask you to promote Dr. Biswas and Sukirti as they are our discussants. Maybe they want to add some more hints to the discussion. But I have a question. Calvin, you very nicely described the indications for this kind of surgery. My question is, what are the contraindications for this kind of approach?
Good. So now, first of all, I have to say that we're still in the beginning to adopt this bipodal technique. So we're still exploring the best indication. I would say instead of contraindication, I would not routinely use a bipodal technique to remove a NOP3B or NOP4 tumor. In the recent case, it's a NOP4. I try to remove it from the endonasal first, and I can remove everything. So for that case, I did not open the transorbital route. And another, if we talk about contraindication for bipodal, of course, if there is a previous transorbital surgery done, which can be a hindrance because of the fibrosis and the fusion. But otherwise, to be honest, I don't see at this moment an absolute contraindication for adding in the bipodal port in addition to the algorithm. It's a matter of whether it's necessary to add in the transorbital route or not. So although I'm kind of sharing this technique, it's a new technique that we are adopting since last year, but practically I'm more conservative. It makes more sense, is to remove everything from the lowest possible instead of creating a new corridor. But sometimes we need to add in that corridor, as Roger mentioned. In certain cases, we can actually avoid doing radial surgery. For example, one of the cases that I showed.
Thank you, Calvin. Is there any other question from the audience?
We have Vishwas and Sukirti.
Biswas and Sukirti. Hello, good to see you.
Hello, Albert sir. Hello, Kelvin Mac sir and Raja sir and Kato sensei. It's always great to enjoy the presentation from Kelvin sir. Just one question. So when there is a cavernous sinus invasion, and if we go transpterygoid, endoscopic, endonasal, both in the coronal and sagittal plane, the internal destruction is less compared to if we go both endonasal and also transorbital. Just definitely it's very good innovation and we should adopt this. But in comparison to both approaches, how do you consider this?
Yes, thanks for the question. In the past, of course, I for all these cases, I do the extended transurbital approach to the natural cavernous sinus. Now, first of all, there's a lot of nasal mobility. Imagine the sinuses that you have to destroy. So it creates a lot of mobility with these patients. And pituitary adenomas, they are financially. So we'll be very careful about the complications and the discomfort that the patient needs to live on. If it's a malignant tumor, then we say to the patient, it's a malignant tumor, it's a cure. So you have to bear with the side effects of this. And secondly, the Vidian nerve and the Vidian canal often has to sacrifice, and this can lead to dry eye. And if the tumor also involves the V1 with numbness, then it will have problems with the cornea as well. And also, we need to actually lateralize the carotid artery in some certain cases in order to remove, especially the more inferior part of the lateral cavernous sinus. So that will actually create risk to the carotid artery, not only for the external bleeding like rupture, but it can also lead to the internal tear, which will not be visible during the surgery. So that's why in these cases, I would consider adding the transorbital being safer.
Okay. Thank you, sir.
Thank you, Biswas, for your question.
Thank you, sir.
Other questions from the audience?
Hello, Dr. Calvin. Thank you so much for your lecture. And I'm so impressed with his surgeries that I have indirectly applied to him and said, yes, I want to see and learn. Because the concept of going intra-orbital is the most interesting concept. So what do you say that once we have expertised ourselves with transnasal, adding it on, how much do you think is the learning curve for the young neurosurgeons?
All right. So if I sorry, the audio is not very nice here, but if I get your question right, it's about the learning curve, right? Yeah. Okay. Yeah. In the beginning, now I've done around almost reaching 80 cases. I only started doing bipportal surgery after doing around 30 cases. So in the beginning, the 10, 15 cases, to be honest, is exploring everything. You are not very sure how far we can reach. And after that, when you master about the anatomy, then for me, I start to add in other indications and biphoto as well. Because there are risks, and you have to explain to the patient why, and you justify as well, why do you need to open another scar, another wound, which can cause additional morbidities. So it's important to the patient focus, and you have to be sure that you already master the anatomy and the surgical skills to work in small corridors. So cadaveric dissection is very important to start and also to accelerate the learning curve. That's my view.
Thank you. Thank you.
Thank you, Sukirti, for your question. Other questions? I don't see other questions from the audience. So I want to thank very much Professor Calvin Mack for joining us and finding the time to have this wonderful discussion, although he's traveling. So Calvin, have a safe flight. And we will surely join your Congress, Young Neurosurgeons Congress in Hong Kong. We are looking forward to it.
Thank you very much. Thank you.
Thank you.
And thanks again for the invitations. Thank you.
Thank you, Calvin. Bye-bye. Thank you.
Bye-bye.
Thank you. And we can move to the second speaker. I don't think my co-moderator and friend, Professor Ishu Bishnoi, was able to join so far. So I will take the pleasure to introduce our next speaker, who is Dr. Niveditha Manjunath. Dr. Niveditha Manjunath is a consultant neurosurgeon in independent practice in Bangalore, India. She has recently completed a cerebrovascular fellowship at the Fujita Health University Bantane Hospital. She will talk today about trigeminal neuralgia in recurrent and complex pathologies. So it's a very, very interesting topic. Thank you so much, Niveditha, and you can start sharing your screen in a full size. Thank you.
Good evening, everyone. Thank you very much for this opportunity. I'm very grateful to Professor Kato and to all of the to everyone in ACNS, as well as also the Fujita alumni as well. So today my topic will basically be entity for trigeminal neuralgia and recurrent and complex pathology. I was very lucky to visit Fujita Health University Bantane Hospital on 7 March of this year, and I witnessed a lot of endoscopic MBD cases and by Professor Kamaku there. And in the process of the same, I did a case report on trigeminal neuralgia in recurrent and complex pathology. So it gave me the opportunity to explore the topic a lot. So I decided to present on the same. So coming to the introduction, trigeminal neuralgia, as you all know, is characterized by episodic sudden onset transmitting pain, which affects one or more divisions of the trigeminal nerve. And this is the definition is given by the International Association of Headache Disorders. It is again divided into 3 types, which is basically primary trigeminal neuralgia, where around 80% of the cases are caused due to compression by the superior cerebellar artery, and a small subset of cases are caused by compression by the veins, such as the pectoral veins, or even due to the compression by IPA. Sometimes there is a double compression by both the superior cerebellar artery as well as the IPA. And in rare cases, there is compression by the vertebrobasilar complex, and very rare cases we encounter the vertebrobasilar dolichoaspirator as a cause of compression. Secondary causes, which I won't be talking about today, are of course neoplasia, epidermal cysts, pelvic anomalies, infections, inflammation, multiple sclerosis, and post-surgical trauma as well, which might cause trigeminal neuralgia. And idiopathic trigeminal neuralgia is a small topic that I will be touching upon today as well. So in idiopathic trigeminal neuralgia, there is no identifiable cause and image, and all the other diseases have been excluded as well. So coming to microvascular decompression, it was introduced by Mehta in 1980, and it was initially introduced as a modification of the supracellular infratemporal approach to the procedure for solution. The aim of the surgery was, of course, to eliminate the contact between the ascending vessel and the nerve using a bicompatible material. So initially when it started, various materials to use, muscle pads, dura cells, or even cotton pads, or even cotton packing. Later on, of course, Teflon became a very popular substance because it is inert and biocompatible. And of late, we have seen more materials being added. Transposition is another technique which is initially introduced by Fukushima, and it involves basically separating or dissecting the vessel of the nerve and attaching it to the dura. Again, the nerve vessel can be basically attached to the dura by using either the pericranium, using the Teflon sling. Of course, I have commonly seen that the master doing it using fibrin glue, which is very effective, and it's a very good technique, I would say. So both the techniques have been found to be equally efficacious, and approximately 82% of the patients experience complete or immediate pain relief. And patients who experience partial pain relief are also extends the number further up to nearly 90 to 95%. So there have been quite a few advances in MBD since it was initially introduced. The major advance is that it went from being a large craniotomy to a smaller tailored craniotomy. First, nowadays we do just a small point craniotomy which is centered around the area of interest. Endoscope assisted or fully endoscopic MBD was another thing which was introduced initially by Fukushima, and then it became more and more popular. And at present, there are a large number of people all over the world who are performing fully endoscopic MBD, which is truly a very remarkable technique because of the panoramic view and the 360-degree view of the nerve, vessels, and the beautiful view which is provided by the team, and also the fact that there are no blind spots with a endoscope which is utilized in the MBD. And the other advancement which has enabled us to perform these surgeries more successfully is the shift in sentinel monitoring, and of course the auditory brainstem response as well, which play an equally important role in ensuring that the patient undergoes safe and effective surgery as well. Fluorescence radiography is another important advance, which helps us identify the vessels which are actually causing the compression very accurately. The latest advancement is MBD and the endoscope. So usually this is both a combination of endoscope as well as endoscope, and it's particularly useful when there are residents or students around, because it helps them gain a comprehensive view of the surgery which is being done, which might be missed when we're doing microscopic surgeries. So, of course, Professor Kamasu has popularized the endoscopic MBD. Endoscopic MBD, along with the use of indocyanine beam, is another advancement we recently came about. And the latest advancement we came across when it's discussing for this particular webinar was awake neurosurgery, which I found quite interesting, although I'm not very sure if it would be immediately adaptable in India or not. So that is another interesting article, I think so. So coming to the various complex pathologies which cause trigeminal neuralgia, roughly 2 to 10% of the cases of trigeminal neuralgia are attributed to vertebral vessel dolichoasthesia. So in this particular anomaly, it is considered to be a congenital anomaly which evolves in due course due to atherosclerosis and also because of arterial hypertension as well. The symptoms of trigeminal neuralgia in such cases occur due to the compression of adjacent structures which are added into the abnormal veins and hence cause compression of the nerve, or even as a result of ischemic events due to this particular axial anomaly as well. The direct compression, however, by the vertebral vessel dolichoasthesia is very rare and accounts for barely about 1% of the cases. There are two MRI sequences which have been found to be very useful in evaluating these particular cases, as mentioned by this study by Campos et al., which was CD-CFTR sequence, as well as also the contrast-enhanced T1-weighted imaging, which helps us identify the vessel and its relation to the brainstem as well as also to the nerve, and we're able to visualize the actual diameter of the vessel and plan accordingly preoperatively before we go in for the surgery. So these two are very important sequences. Bobo and Zedar basically established what vertebrocellular dolichoasthesia is according to the criteria that they emphasized on MRA. So this is a small, this is basically a small slide in the same regarding what their criteria was. So coming next to how this is particularly managed. The vertebrocellular dolichoasthesia, like any other case, is initially managed by microvascular decompression. Transposition into position techniques are initially attempted. Of course, as I already mentioned, of late, endoscopic or endoscopic microvascular decompression for trigeminal neuralgia caused by the vestibular artery. This is a very interesting case series that was written or published, in which they basically performed the surgery successfully in 26 patients. Which the cause of the compression was not just by the vertebral artery and vestibular artery, but also by concurrent other arteries, like the ICA and the FCA. And in this particular series, they were able to effectively mobilize the vessel away from the nerve and achieve complete pain relief in majority of patients. And the same was observed over a 45-month follow-up period as well, which I found to be quite interesting. Of course, because this pathology is very complex and different. There have been different approaches which have been utilized as well, such as two very rare techniques that I came across were, one is the anterior transpetrosal approach for microvascular decompression, which was done in, which was a study from Japan, which is quite interesting because they were unable to approach this particular anomaly, which is causing trigeminal neuralgia via the conventional retrosigmoid craniotomy. And as such, they resorted to the anterior transpetrosal approach. Another very different approach which is performed for the dolichoectasia was from Barrow Neurological Institute, in which they were unable to utilize the conventional MBD or even the macrovascular techniques to carry out the transposition of the vessel, and hence they resorted to what they called as a binding bypass, in which they transected the vessel and then they reanastomosis it lateral to the nerve so that it didn't cause compression anymore. So these are very two different techniques that I found very interesting. Of course, they should only be utilized when the conventional MBD techniques fail, which is very rare again. Trigeminal neuralgia due to venous compression. This is very important, as in a number of cases, veins alone are found to be causes for the compression and responsible to the symptomatology of trigeminal neuralgia. So, vein-related trigeminal neuralgia is primarily attributed to the superior petrosal vein, as well as also to its tributaries as well. So, often sacrificing the causative vein is unavoidable, and especially more so when the vein passes through the band of nerve fibers and no other offending artery can be found. And in such cases, there is no other possibility than to sacrifice those veins. That being said, we have to be very sure that there is collateral venous flow before we can go ahead and sacrifice the vein, or it can result in venous infarction and serious symptoms. And the most common adverse effect which can occur due to this sacrifice of the vein is facial numbness, which is quite debilitating for the patient as well. So this was a review which basically tried to determine the different approaches which are utilized when a surgeon encounters venous compression because of trigeminal neuralgia in cases of MPD. So they found that in 15 studies which encompassed 600 patients, nearly 82% of these patients basically were able to achieve complete pain relief over 12-month follow-up period. So in 600 of these patients, the cause of compression was venous. And the various techniques which we utilized were coagulation cut of the causative agent. And this is particularly favored when it is a smaller vein, and in those cases in which they were sure that there was collateral venous flow, and that sacrificing the particular vein did not cause any deficit. And that there was no other option, as the vein could not be transposed to solve. Interposition and transposition were primarily used when the vein was slightly larger in diameter, and then there were positive occlusion tests, or basically when there was no other collateral venous flow, and then sacrificing the vein would definitely result in adverse events. So in these particular cases, they decided to perform an interposition or a transposition. In one study, they decided to sharply dissect and cauterize the arachnoid first to mobilize the vein away from the nerve, and then followed by which they create Teflon, which is another interesting technique that they utilize. So this was an interesting article, which is basically from Tokyo, where again, like previously mentioned, they encountered two different cases. So in one of the cases, they found that the vein, the cause of the venous compression was the vein of the cerebellopontine fissure. And this particular vein was, seen that it was both intraoperatively and preoperatively, it was seen to be draining a large area of the brainstem. And as a result of this, they could not sacrifice it, and hence they decided to transpose it. This is another case in which they basically thought that there was ICA as well as also the vein of the cerebellopontine angle, which is basically passing through the nerve. So in this case, they were able to successfully transpose the ICA, and they were able to divide the vein of the middle cerebellar peduncle successfully, because they found that there was collateral flow, and hence it could be sacrificed safely. In this particular case, in this particular series, which was published regarding how to manage ascending veins in trigeminal neuralgia for microvascular infection, they found that sacrificing the veins, especially in 14 patients, resulted in venous infarction and facial numbness. And in all of these patients who suffered venous infarction post-operatively, which was identified on the MRI, these patients developed permanent facial numbness as a deficit, which is quite significantly debilitating for them. However, in a majority of patients, they did achieve complete pain relief over a long follow-up period of nearly 48 months, which is quite effective. Coming to idiopathic trigeminal neuralgia, so this is one particular pathology in which there is no compression which can be identified, no neurovascular conflict, and in which no other medical causes are attributable for the cause of trigeminal neuralgia. So it counts approximately 10% of the cases, and most of these patients fail medical management. And in them, microvascular decompression is offered as a choice while explaining that it may not work completely as well. So in these particular cases, what has been found to be effective is internal neurolysis. So internal neurolysis, the foaming of the nerve, basically involves gently massaging the nerve or dividing gently into particles so that there is more effective transmission to the nerve and so that the pain comes down. So careful dissection and lysis of the surrounding arachnoid over the nerve has also been found to be equally effective as well in case no neurovascular conflict has been found. So in all of these cases in which internal neurolysis was performed, nearly 85% of the patients were found to be pain-free, and nearly 96% experienced a decrease in the amount of pain that is present preoperatively, and the 1 in 5 year pain-free survival was also quite significant as well. So in trigeminal neuralgia, the technique is not just limited to neurolysis alone. There are a number of other techniques which have been described, such as in this particular case study, they described what is known as the wrap technique, where they just went ahead and they wrapped the Teflon felt inferior to superior around trigeminal nerve. And they utilized the trigeminal hypoglossal reflex as a marker for adequate decompression. So if this trigeminal hypoglossal reflex was found to disappear following surgery, then it is considered as a marker of complete decompression. And in all of these patients, they found that although the case number is quite small, 6 patients, but they found that these patients remain pain-free 18 months. This is another study which compared the efficacy of microvascular decompression to percutaneous balloon compression. So it is found that although they had similar rates of pain relief, it is found that the microvascular decompression group had lesser amount of complications as compared to the percutaneous balloon compression. And also the pain-free survival as compared to the percutaneous balloon compression group, the rates with MPD were obviously better. Coming to recurrence, now this is a very important. This is very important as time goes on because a lot of cases we might encounter a lot of cases in the future of recurrent trigeminal neuralgia. So it is basically described as the recurrence of pain on the same side as the initial pain, so repeat 6 months after the performance of the initial successful MBD procedure. So it is a very well documented pathology, and the percentage of patients who remain pain-free following surgical decompression has dropped to nearly 44%, as per this particular study by Barker and Janata et al. This following surgery has been reported to be around 70 to 40% in various literature studies as well. So although the number is quite large, various different studies have reported it as different numbers. So it is quite an important pathology. So the causes are varied. One is because of Teflon. It can be an overstuffing of the Teflon, dislocation, or even granular malformation. Vascular conflict is another common cause in which there may be inadequate initial mobilization of the artery or the vein away from the nerve, or there may be formation of a new conflict, which is more likely in cases in which there was a dual compression to begin with, or there might have been vertebral asphyxia, which is evolved over time, or even inadequate surgical techniques in which there was inadequate surgical dissection initially, or even formation of arachnoid granulation over time at the surgical site. A very small subset of cases, there is no identifiable cause found even preoperatively or intraoperatively. So Teflon granuloma is one of the most important causes for recurrence. So in this particular scenario, patients often complain of extension of the initial pain to other divisions of the trigeminal nerve itself. So the cause of the recurrence is often attributable to the piston effect of the Teflon granuloma. That is basically the pulsatility of the artery is transmitted through the Teflon granuloma onto the nerve, and hence there is spread of the pain more than the normal divisions that initially the patient presented with. So there were various theories for the causation of the Teflon granuloma. One was contact with the dura and nerve, which of course is inevitable, and hence these theories were discarded. The latest theory, however, is hemorrhage into the Teflon granuloma. So the theory basically says that as a result of the hemorrhage into the Teflon granuloma, it basically gets organized into sort of a granulomatous inflammation, and it becomes like a foreign body inflammation site. And there is infiltration of multinucleated giant cells and lymphocytes, and often intraoperatively a reddish brown Teflon granuloma along with microcalcification is usually encountered. So on imaging, normally we can, on CT, basically show the hyperdense site, the Teflon granuloma is present. On MRI, we show as an agglomerate signal or even thickening of the trigeminal nerve as well. And histopathological examination shows foreign body granuloma formation with birefringent Teflon filaments, as well as also multinucleated giant cells, hemorrhage, and microcalcifications. And it's also stained positively for the leukocyte common antigen or BCC. So the variants, so of course, for Teflon granuloma, again, if it is identified, the only available resort to the surgeon is to go and relook and to dissolve the granuloma, dissect it, and to remove it out. However, there are a number of studies which try to deal with this particular complication by exploring the different materials which are available. So Evolon is one such material which is available. It is a small absorbent sponge, and it is thought to be comparable in efficacy as compared to Teflon, although the rates of recurrence was also quite similar. So it is difficult to say, and most studies might probably be needed in order to find out if the recurrence rate might actually be lesser for Evolon as compared to Teflon. Another study basically explored the possibility of basically placing the Teflon felt in a different shape as compared to the usual cigar roll shape in which it is usually placed. They try to place it in the form of nest shape and try to see if there was any improvement in the recurrence rate. Although they still saw that there were approximately 11.1% of the cases. But in all of these cases, they found that there was no Teflon adhesion or Teflon-induced granuloma which is formed post-operatively, intraoperatively during the during surgery for the recurrence. Another study basically explored the possibility of placing an expanded polytetrafluoroethylene sleeve as done in vascular surgery in order to cover the nerve completely, so that it is completely decompressed. And they found that this technique might probably be useful, especially when there is a dual compression from two arteries, particularly in trigeminal neuralgia. Those are quite rare, but they thought that it might be particularly effective in such cases. Also, because of the fact that it is semi-elastic and semi-rigid, it might cause lesser amount of force in the nerve and hence provide better decompression. So another interesting fact that I came across was there is what is known as shortening of the trigeminal nerve in a few cases of recurrent trigeminal neuralgia. And this particular study explored the same. So they found that in a number of their cases, they found that the trigeminal neuralgia, they found that the trigeminal nerve, as compared to its appearance prior to the initial surgery and its appearance following its appearance during the recurrence, there was quite a significant shortening of the nerve. The length during the initial surgery was found to be 14 mm, and it had shortened to approximately nearly around 5 to 7 mm prior to after the recurrence had occurred. So there was a lot of theories which were put forth this. As a result of the shortening, they observed that the pons was pulled anterolaterally, and there was a decrease in the volume of the CT angle system. And as a result, this impact on the nerve conduction may have also caused the increase in the severity of symptoms as well. So there was another study by Pang et al. Who basically emphasized that he defined what is known as the trigeminopontine angle as the reference point. They found that this angle was found to be decreased in patients with trigeminal neuralgia, especially those with recurrent trigeminal neuralgia. So this is quite an interesting finding as well, that the nerve might be shortened in those patients with recurrence due to adhesion or even maybe due to scarring as well. So this is a study which is published from Bantane Hospital. So in this particular case, they found that the patient presented with recurrent symptoms after having been initially operated. And intraoperatively, they found that there was no Teflon granuloma. It was just that there were a few arachnoid adhesions which are basically anchoring the nerve to the dura. And on releasing the same, the patient became pain-free. So it basically highlights the importance of how a redo MBD or basically re-excavation can do the patient a lot of good and help in symptom resolution as well. So there are a lot of studies which focus on a redo MBD, which might basically deter a lot of neurosurgeons because recurrence is quite a big deal for both patients and the surgeon. So in a lot of studies, they found that, especially in this particular study, which is a meta-analysis of various second-line strategies following initial MBD, they found that a redo MBD gave better results as compared to even percutaneous rhizotomy or even SRS as a follow-up procedure in case of recurrence. They found that the early relief, the long-term relief, and the incidence of facial numbness was a lot lesser with a redo MBD as compared to the other procedures. In another study in which they analyzed redo MBD as well as compared to other studies, they found that the initial pain relief as well as long-term pain relief, especially the 2-year follow-up, was better with MBD. So that brings me to the end of my presentation today. Thank you very much for all your attention. Thank you.
Thank you, Niveditha, for this nice presentation about MVD. And now I would like to ask our commentator, Raja, to give his comments. Thank you.
Right. Thank you, Niveditha, for this wonderful presentation. You covered a lot of things about trigeminal neuralgia. Basically, you have touched upon the recurrent cases. I would love to know about the complications in recurrent, because in primary you have very less complications. I assume the recurrence should have more complications. So how is it in the current Bantane series, like in the primary versus secondary? I know the complications of the primary series, but regarding recurrent, what is the data? We cannot hear you. Please unmute your mic.
As such, from Bantane, I don't have any such data regarding primary versus secondary complications. But in the literature review that I did, I found that in case of recurrent trigeminal neuralgia, especially those patients who have undergone MBD, the most common symptoms, like in any other recurrent cases, were of course infections, wound infections, intracranial infections, meningitis. One of the most debilitating complications, however, was facial pain and was facial numbness. So, a lot of patients experience the incidence of facial numbness as compared to the initial MBD procedure was higher in the redo MBD procedure. So in the initial MBD procedures, it was almost negligible, whereas in the redo MBD procedures, it rose to nearly around, say, ranging anywhere from 15 to 30%. So that was quite significant finding. But as compared to other procedures such as rhizotomy or even stereotactic surgery, it was far lesser. And hence, I think MBD, at least based on the literature that I have researched, it should be a more obvious choice for such cases.
Right. So, I would like to mention, we have conducted the Bantane MVD webinar series. We have lots of presentations, and of course, Professor Komatsu is one of the main speakers for our MVD series, and around 819 cases of endoscopic MVD, which is EMVD from the Bantane series. 489 were from trigeminal neuralgias, and the complication rates have been very less. Like hearing loss was reported in 1.1%, cranial nerve 4 palsy is 0.1%, and CSF leakage is 0.4%. Only 3 cases out of a total 819 combined trigeminal neuralgia and HFS. And wound infection has been only very less, 0.5%. So that is the current Bantane series that Professor Komatsu has given us through the MVD series of webinars. And regarding the sacrifice of the petrosal vein is one of the very contentious point in trigeminal neuralgias. So what is your take on this, which I think you did not mention, the sacrifice of the petrosal vein?
So I have mentioned this as well.
Sorry, I did not see that. That's okay. Please do.
Yes, sir. So basically, there's this particular article which had mentioned 2 different cases in which, one in which they decided to sacrifice the vein and one in which they decided to basically just transpose the vein. So I think my main takeaway from that article, as well as reading various other articles on venous compression, was that it's not just a preoperative MRI finding, but intraoperatively also we should identify and see if there is any collateral venous flow. Because if there is collateral venous flow and if that particular area is being drained by more than just one vein tributary, then it is safe to sacrifice the vein. If not, then we should take a chance and just try and transpose the vein or just perform neurolysis instead. Because I think venous infarction, as compared to the series in which this facial numbness was mentioned as a side effect, there might be more devastating effects to the patient as well. So that is my takeaway from the.
Okay. So as you rightly mentioned, there have been cases of infarction reported in plenty of cases. There is a recent neurosurgery journal, this current edition has come up with a series of around how many cases? 310, I think, in which they have reported sacrifice of the petrosal vein, and the incidence of infarctions have been 0.6%. And in also, but the meta-analysis which say with or without sacrifice the petrosal vein, there is not much of a difference. But the conclusion is that if there is any point to save it, you must save it without sacrifice. That is a point. So, and between interposition and transposition, which does have the higher complications, right?
Interposition, I think one of the things that even probably, like, I think interposition probably has the higher complication rate, probably because one thing is that Teflon is one particular thing which no one knows how much exactly the stuff. There is no exact consensus on how many Teflon cells should be placed, how much is the right amount, how much may cause adequate decompression, how much is too little. So it may cause effective decompression or it may result in a Teflon granuloma. Transposition, on the other hand, especially the way Professor Kamasu does it, it's quite beautiful because he just secures the vessel using fibrin glue. And I've seen that it's quite effective when patients have adequate pain relief as well. So, and even in the series, although in a lot of series as well, they did cover it, that both interposition and transposition are equally effective. But yet the recurrence, which is usually identified in a lot of cases, it is because of Teflon granulomas or even because of adhesions which have formed as a result of these interposition drugs itself, if not directly because of the Teflon.
Right, Teflon granuloma is obviously a very known complication, but it is very rare. In the current literature between interposition and transposition, the complication rates have been more in the transposition, because you are moving the artery long enough so that small perforators get avulsed. That is why microinfarcts, CSF leaks, all these have been reported more in the transposition rather than interposition. So we will open this for our other discussions as well.
So Raja, in your experience, you prefer interposition?
No, we always do transpose. No, sorry, interposition only.
Interposition.
Yeah, we have never done a transposition.
I used to do interposition, but now if it is feasible and you can get it only intraoperatively, I try to do transposition. Of course, if there are no vessels that might be, evulsed and stretched too much or broken, I try to do a transposition because I feel like there is a better long-term effect. But of course, I agree that in case you choose this kind of technique, you have to be very careful.
What you said is correct. In terms of pain relief, both are same. There is not much of a difference. But complications have been more with transposition. That is the takeaway in that. And I think you must not have a hard and fast rule that I will only do this. You have to curate on the basis of each cases.
Absolutely. Yes, absolutely. I totally agree. Any question? Yes, I see Ben who raised his hand.
Just a quick question. Since we're talking about the transposition, I would like to ask about do the complications of the transposition related to the method or material that we use in the transposition. There are different types of techniques reported in the literature for the transposition. Will they relate to the complications? And then any comment?
I think it's related to the, I don't think it's related to the material so much, because I think it might mostly be related. I think I haven't read up too much on the same, whether it is related to the material or not. But like Professor Raja said, it is mostly related to the dissection of the vessel away from the nerve itself, mostly. Because in the transposition technique, basically we're just securing the dura. So the point of the material itself causing a complication as such, I haven't come across it in literature, but it is something that I'll read up on it, and I think that's something I will probably read up on and inform them next time. But I haven't researched on it. I'm sorry.
I see. Thank you so much.
So Ben, I would like to mention that in LMICs, you will generally see the use of autologous muscle a lot in the large series from LMICs like India, Pakistan, Bangladesh and all. If there are at all using people who are doing trigeminal neuralgia, the availability of Teflon is difficult. So the autologous muscle is the choice of interposition. There was a large series from Pakistan which came out in 2024, around 1025 patients, and this series was mentioned by none other than Professor Moigan Hodai in one of the webinar series. She said this is an excellent study which is definitely a very good alternative to Teflon, and it is almost reproducible pain relief between any other series, and this is one of the main articles that is being quoted in the current literature as well. I would love to hear from Bangladesh and other parts of India also how they do it.
Sir, Dr. Niveditha excellently mentioned technique, recurrence, and other techniques of interposition transposition. So what I would like to mention and pay respect to Professor Komatsu Sensei. But before going to Komatsu Sensei Center, I mean Kato Ma'am's center, usually we used to do a large craniotomy and do it under microscope. But after visiting Fujita Health University, Bantane Hospital, actually it has drastically changed. We have shifted to endoscopic microvascular decompression. Yeah, as you said, Raja sir, the percentage of interposition is more than the transposition in our country. Because if we want to do transposition, we have to use fibrin glue, and it's another cost for the patient. It's almost 32K Bangladeshi taka. So it's a burden for the patient. This is number one. And for interposition, yeah, we use muscle most of the time, actually. Teflon, we don't find Teflon. Sometimes we use cotton, a very thin cotton, for the interposition purpose. There has been drastic improvement in terms of minimal invasiveness. Initially, we used to do large craniotomy, then take the endoscope. But now, after doing cases and cases, we have shifted to a very mini craniotomy and do the pure endoscopic surgery. But Komatsu Sensei has also taught us how to tackle a venous bleed from the petrosal vein. And he suggested that if we put fibrillar or Surgicel mixed with gel foam and give a pressure on both sides of the petrosal vein, then the venous bleed can be controlled without sacrificing the vein. And it's better to preserve the vein at any cost. Because in microvascular decompression in our country, we don't have software like the Amira in Fujita, so that by which we can assess the venous system. But here we just do Fiesta protocol and we have to go for the surgery. So we have to keep in mind that the petrosal vein may be very important for the patient. So at any cost, we try to save it. But just one question, Sensei, to you and also to our presenter, that the atypical trigeminal neuralgia cases are very less in number, but in comparison to the number of classical and idiopathic microvascular decompression, in which portion the recurrence is more in comparison to the number of the patients? Is it the idiopathic one or the classical where there is a microvascular compression?
Classically, it is usually the V3 division, but in one of the studies that I encountered, I may be wrong as well completely, but I found that there were quite a few number of idiopathic cases in which the V2 division was also involved as well. And it was mostly in these cases that the incidence of facial numbness was also mentioned as a significant problem as well, especially in idiopathic cases. So I may be completely wrong. Also, not just in atypical trigeminal neuralgia, in cases also in like Professor Data said as well, although the Teflon ganglioma cases, the incidence is lesser in number, but still one of the common symptomatology that they present with is that as compared to the initial pattern of presentation of the trigeminal neuralgia, there is often a spread to other divisions because of the piston effect, basically because there is a spread of the myelination, the demyelination area tends to increase in the nerve. I think this is a Teflon ganglioma. That's the data that I came across. So I may be wrong. I think Professor Raja might have a better idea on this.
Okay. Raja sir, what's from your experience?
Your question was regarding pain relief rate, right?
Yeah,
Between
exactly.
idiopathic. Right.
Exactly.
So the current Bantane series, I think doctor should listen to the MVD webinars that we usually present. So the trigeminal neuralgia classic, the BNI 1 and 2 outcomes were achieved in 94.5%. And in idiopathic, it was only 56.2%.
Okay. Okay.
That is the current Bantane data that we have from Professor Komatsu.
Okay.
Yeah, this kind of data can be quite common everywhere, right? With idiopathic, the recurrence is usually higher, and actually it's not the main surgical indication for exploration. Of course, we do if there is no other way to fix the patient's problem, but you have best results when conflict is present.
Is present, exactly.
Yeah, I see Sukirti also raised her hand.
Hi, Dr. Niveditha. Excellent talk. I really liked it. You actually have studied a lot to give the talk. My question is a very simple one. Now that everybody is talking about the recurrence part, okay? So my question is, when they plan to do the recurrence case, before that they would have given conservative management for some time. Like, even before doing the primary surgery, we give medical management. So in the recurrent one, how long did that medication continue before, finally telling, yes, you need to get operated? How long will it go?
Thank you very much, ma'am. So basically from the literature, what I got to know was that they classified it as a recurrence if the patient presented with pain at least a minimum of 6 months after the initial surgery. And again, they tried the medication again for a minimum of 6 months period following the recurrence as well. And if the patient's pain was, say, BNI 4 or 5, only then did they go in and reoperate. Otherwise, they try to control it again with medication itself.
I think the connection is not working very well. We cannot hear you anymore.
There is some connection issues there.
Yeah.
We can move on, I think.
Connection issues, I guess.
Because what happens, my concept is once you operate, you just go full blow on with all the medications available. You never want to reoperate.
Yeah, of course. That's a common.
So, and that too an MVD. So is 6 months not a really short time? You try one drug, double the dose, add another drug, add a third drug, give a Botox, do a do something else, till you finally think, yes, I need to reoperate.
Yeah,
So
yeah.
I
You
felt
need to
that
convince
way.
yourself and the patient about the need to do a redo surgery, right? Takes time sometimes.
So I think the threshold for resurgery was pretty less in these cases among all the studies that she had done.
Yeah. Niveditha, do you want to try to finish your talk?
Am I audible, sir?
Oh, yeah. Now, yes.
Yeah. Yes. So I agree as well. But the thing is that in all of these recurring cases, they have said that mostly the time for recurrence, of course, is varied. But then they have said that following the recurrence, they've tried to maximize the medication. But despite medication, if the BNI has been 4 or 5 and above, then they have decided to go in and redo the MBD or redo whatever other second line management strategy that they have for the patient. But I think it's the same, that they already sent it may not work for the patient, that patient may not have complete pain relief, or patient might not even have partial pain relief as well. So I think they haven't exactly mentioned the waiting time, but then they mentioned that the minimum period was 6 months. That's what they said. So. Thank you.
Thank you.
Thank you.
Any other comment or question? If not, I want to thank both our speakers today for wonderful presentations and very active discussion. Thank you also to our discussants, Sukirti and Biswas, and our commentator, Raja. I would like, before asking the current fellows to introduce themselves, I would like to ask Professor Yoko Kato to give some words to comment this webinar. Thank you, Professor.
So, Dr. Calvin, I heard many times of his presentation, but the transorbital is maybe the usual and maybe some kind of a dissection study, and also to know the anatomy is very, very important. And also the Komatsu surgery, I see that every day, 3-4 cases. I think his surgical technique is very, very simple, and finish is less than 1 hour. So much shorter than before, I think you joined. And the transposition is, of course, sometimes the perforators complication they avoid. We need to avoid, but I think recurrent is much less than you expected, I think. And that's all. But I think anyway, it's very simple. And also the preservables are, of course, petrosalvane is very important, I think. So, and sometimes I encounter some complication, some the hearing, how to say, some noisiness, and also the not double vision, so what's an English name? But anyway, some eye disturbance, movement disturbance sometimes happen. But it will recover in one month. And also the microvascular compression of this, or the hemifacial spasm, so we can see that at least one year. And also the trigeminal neuralgia, maybe we do the recurrent surgery in a 6 months, I think. So the hemifacial spasm, you can wait till one year, I think. Thank you very much. It was a wonderful webinar.
Thank you, Professor. Yes, actually, I also agree that neurosurgery is nowadays moving towards simple approaches and simple techniques. It's easier, and also it's easier for young neurosurgeons to advance in the learning curve. So we really need to aim to simple approaches and techniques. Of course, having always in mind that they must be effective for our patients and safe as much as possible. Thank you, Professor. And at this point, before closing this webinar, I would like to ask the current fellows at Bantane Hospital to briefly introduce themselves. So maybe Dr. Huyn from Vietnam.
Atik.
And Atik and also James. I don't know if they are connected. Yes, they are. Ubong Essien also.
Atik, mute please.
You can start with Atik, I think.
Atik first.
Yes, hello, good night, good night,
Yes.
Sensei. I am Dr. Atikur Rahman. Am I audible?
Yes,
Yes,
you are.
yes, please go ahead.
I am Dr. Atikur Rahman. I am from Bangladesh. At present, I am working at National Institute of Neuroscience, Dhaka. I am here under Professor Kato Sensei for 2 months. And my interest is endoscopic neurosurgery and vascular neurosurgery. Thank you all. Good night. Bye.
Thank you, Dr. Atik. And maybe next can be Dr. James.
We cannot see you, James.
James is online, but we cannot hear. Maybe you have to activate your mic.
Hey, good evening.
Yes.
Hi.
I think we are all in one room. I'll join with my colleague's camera.
Yes, please.
Maybe my laptop has a problem.
Sure, you can introduce yourself.
My name is James Q. Loco. Hopefully you can see me on Obong's.
Yes, yes.
On ACN's camera. So I'm from Kenya. I'm a consultant neurosurgeon, recently qualified. So I still haven't developed a specialty yet. However, my main interests are vascular neurosurgery and functional neurosurgery. And I'm gratefully thankful to be here with Kato Sensei. My first time meeting her was last year's winter conference, and I was really amazed by the quality of work done here. So I'm back this year to learn even more. Thank you so much.
Thank you, Dr. James. Thank you so much. Maybe Dr. Ubong Essien can be the next one.
Good evening.
Good evening.
Thank you very much for the opportunity to briefly introduce ourselves. My name is Dr. Ubong Essien. I want to use the opportunity to thank Professor Kato for the opportunity to learn under her. I'm a Nigerian. I work with National Hospital Abuja in Nigeria, West Africa. I'm also a recently qualified neurosurgeon with interest in endoscopic skull base and vascular neurosurgery. I intend to learn beyond that under Professor Kato. I'm happy to be here, and I'm sure going forward, I pledge that I would be a good ambassador of these alumni. Thank you.
Thank you, Dr. Essien. Thank you so much. And finally, we can ask Dr. Huyn.
Hello.
Hello.
Hello, Professor. Hello, Professor Kato. Maybe something wrong with my computer. That's why I need to use my friend. I just know him just half a day, but maybe I think he's the best friend in the future. And also, this is the first day in the 7, and always everything is new to me and I need to learn. And it is so my pleasure for me to join in this group today, and maybe in my in my experience it's so new experience for me to see all the expert room all around the world. And it's also my pleasure to meet because my boss is I'm in a big hospital in Vietnam, and my boss also do a lot of in neurovascular surgery like your case. And in Vietnam we just apply surgery for trigeminal neuralgia and hemifacial spasm, and we just apply RF for this pain, for this facial pain. And when you represent about a lot of technique about neuralgia, oh I see. Oh, I just want hit in my mind. That's okay. Learning curve is so long and so many things I need to learn more. Okay, I still young in this field. Okay, thank you for your sharing me a lot of knowledge. Okay, thank you.
Thank you so much. Thanks to all of you, and of course, from our side, the best luck for your experience in Japan. You will be able to see wonderful surgeries. Not only that, you will for sure bring back to your country nice memories from a cultural and social point of view. We are all aware of that because we had the same experience when we were in Japan. So good luck to all of you. And thank you for your self-introduction. At this point, I think we can close this alumni webinar. Thank you all for attending, to the speakers. And thanks to the discussants, of course, and Raja as a commentator. A special thanks to Professor Yoko Kato for always leading us. Thank you and have a good